All right, April 22nd. A couple of questions so far.
Okay. Just the two.
Yes, so far, yep.
Okay. Dr. Gonzalez, is it recommended to wear the stage one while using froggy mouth, or should the exercise be done with the mouth clear for better results? So if froggy mouth is appliance designed by French orthodontists that trains the patient to focus on the internal componentry of the swallow, right, to eliminate lip activity, mentalis activity, buccinator activity, and just focus on teeth together, tongue to palate swallow. Its purpose is to change the swallow pattern from a teeth apart suck swallow where it's facial muscle activity and the tongue kind of coming back and forth, or in a thrusting action. An adult physiologic swallow is where the lips are softly together, there's no facial activity, the teeth are in contact, maximum intercuspation, and the swallow is with a liquid or semi-liquid or bolus, where the tongue tip reaches the incisive papilla and then progressively squeezes back to the soft palate. The froggy mouth moves the lips out of contact, and in order to swallow the saliva that builds up correctly while maintaining the position of the froggy mouth, the child is forced to contact teeth in maximum intercuspation and then organically develop a tongue peristalsis from front to back swallow pattern. Now, this process only works if we have a roughly class 1 relationship with minimum crowding. The process doesn't work with a significant class 2 or 3 or hyperdivergent relationships. It might work with a hyperdivergent relationship. But it's not really designed to be useful with a significant malocclusion. So from a treatment perspective, in postural orthodontics, we use the froggy mouth to augment, supplement, to coincide, to encourage GoFX, a good oral finishing exercise. So good GoFX is effectively the same process as froggy mouth, right? The sip, smile, swallow, click. GoFX process is effectively the same as what the froggy mouth achieves. So in postural orthodontics, we do GoFX at the end of the treatment when we are appliance free. So in order to maximize the effectiveness of froggy mouth, we don't have any appliances in the mouth, and we are at the end of the structural rehabilitation steps. So no plates in when we're using froggy mouth. That's the short answer. Next question. When wearing stage 1 appliances and the second primary molars fall out and you need to maintain leeway space for future canine eruption, what point do you scan for the stage 2 retainer? As soon as the ears get really loose, right after they exfoliate, which will often be at a different points in time. At this point, we also have bicuspids erupting, partially erupted. So a stage 2 appliance is what we call a changeover appliance. Right? It's a retainer that holds leeway space and holds transverse dimension. Now, it's clasping incisors and 6-year-old molars. So it's independent of the primary teeth or the changeover of premolar eruption or canine eruption. So it's designed to hold leeway space. So we know that the second the ears fall out, leeway space starts to close. So your stage 2 appliance, if you want to hold leeway space, must be in place before the first E falls out. If you wait until the E falls out or gets loose, the existing stage 1 appliance will not fit and cannot be worn. When you have had a history where you've expanded using a stage 1, and then you start wearing that appliance, relapse happens overnight. So if you wait until the E falls out or gets so loose that the plate doesn't fit any longer before you do the scan, and it takes you 2, 3, 4 weeks, 5 weeks before your retainer stage 2 is made, the chances of you being able to fit that new appliance after 2 to 5 or 6 weeks of being appliance free is nil. So if you're going to hold leeway with a stage 2 retainer, it has to be in place before the E falls out, and sometimes in place before the E gets so loose that the stage 1 can't be worn. Okay, next question. There are many cases of missing teeth not impacted in my practice in non-syndromic children. Missing premolars, usually bilateral 2 to 4 missing. Lower incisors, 1 or 2 missing. Upper laterals. Please explain how you would treat these cases for 12 years of age and explain to their parents. Have any parents insisted on closing the space to avoid implants in the future? So missing permanent teeth is always a headache, right? Literally pain in the mouth. Managing missing teeth is always a lifetime of compromise. Not having wisdom teeth is simple management. Not having premolars is a little bit more complicated. Not having incisors is a real aesthetic pain in the mouth. So when we have missing adult teeth, conversations need to be brought up with the parents saying, this is a major problem. All right? It's a lifetime management issue. Now, that said, will it affect function? Unlikely. Will it compromise eating capacity, chewing capacity? No. Will it upset speech? Unlikely. Will it be an aesthetic concern? Only if it's an upper lateral incisor. So as far as management is concerned, which teeth are usually missing? And which teeth are problematic for aesthetic management? Least impactful, easiest to manage is a missing second premolar. So commonly the second premolars are missing. Maybe next most commonly would be upper lateral incisors, and then the least most common missing would be the lower incisors. Missing premolar. More often than not, a lower premolar is missing than an upper. Upper missing premolars are the easiest to manage. When the because missing upper second premolars means that there'll be a space, and the 6s and the 7s and the 8s just naturally close up that space. So the management of a missing upper premolar is often extraction of the upper E's, and then the 6 closes leeway space, and the 7 moves into the 6 space, and the 8 usually moves into the 7 space. So that's usually how missing upper second premolars are managed. Missing lower premolars are much more difficult because leeway doesn't usually close properly. Usually what happens is if the E is lost or extracted, the 6 moves halfway along and tips over. So the choice will be extract the E and then let the 6s drift, and during the teenage years mesialize the 6 and the 7 as if you had done a premolar extraction. So not a difficult orthodontic issue to manage. It's a routine orthodontic mechanics management issue. What are the alternatives? Preserve the E for the next 10 to 20 years. And then when the E fails eventually in the 30s or late 20s, to either accept a space or have an implant or a bridge. What is simpler, less involved for the child come adult, and is obviously orthodontic space closure. So generally, most people will choose orthodontic space closure compared to an implant or a bridge in the future. Next would be the lower incisor. If one is missing, usually you accept 3 lower incisors down the bottom, and usually you have no crowding. Sometimes the space just self-manages. Other times you just do orthodontic shuffling. There'll be a Bolton's discrepancy, so the arch form in the upper will be slightly greater than the lower. You can either accept it, or you can do interproximal stripping of the upper to better coordinate the arches. Very often it's just accepted. There's Bolton's balance, and the upper arch will be very slightly bigger than the lower arch. If there's 2 missing, you're going to struggle with arch coordination because you're literally going to have a big discrepancy in arch form. You can develop the arch, but replacing missing laterals in the lower is a real pain. Right? You can do an implant, you can do bridge work, but don't forget this is a young child and can't do implants until late 20s, early 30s. And bridges are limited to Maryland bridges, and it's a real pain. So more often than not, you accept there's an arch form discrepancy. there's 2 missing laterals. These are all complex decisions to be made with the specialist orthodontist and restorative dentist. The anticipation is for long-term restoration. The one that has everyone scratching their head the most is, of course, missing upper laterals. If you miss 1 versus missing 2, it's equally complicated. The solution for a missing lateral in the anticipated long term is either canine substitution or holding space for bridge work or implants. Historically, the most common solution was canine substitution. So you do fixed ortho to consolidate the space by bringing everything forward so that the canine exists in the lateral position and the premolars come forward. And you have the first premolar acting as the canine and the canine acting as the lateral incisor. Once the orthodontist has moved those teeth into the positions, then you will end up with a restorative compromise because you'll have first incisor followed by a canine followed by premolar. And of course, the canine looks nothing like a lateral. Premolar looks nothing like a canine. At that point, you consult with the restorative dentist and they'll recontour the canine and build up the canine to look like a lateral, and the same with the, they'll build up the premolar to look like a canine. In the initial phase, it'll probably be with composite restorations. In the long term, probably porcelain veneers, once we get into the 30s or so. If there's 1 lateral missing, then the decision will either be, oh, no, let's go back. So if the decision is that you're going to maintain space and replace the missing lateral, then you reopen space or you manage space if the teeth haven't drifted forward already. So if the teeth are already drifted forwards, then that's already your answer, right? You're going to do canine substitution. If the teeth haven't drifted forward and you anticipate the fact that the canine is the only tooth that's going to come through between the B and the C, is that you hold space. Once you've realigned the central and the canine into its correct position, then you'll use a Maryland bridge to replace the lateral at the end of the orthodontic phase, and you will hold that space until late 20s, early 30s before you consider a implant. If you're missing 1 lateral, then you have to make a decision to either correct unilaterally the missing side only with canine substitution or space maintenance with the Maryland and then long-term implant. Some orthodontists will have the discussion with the parents and they will electively have you take out the other lateral and then close the space with canine substitution. So how does the parent and the child make the decision? Well, obviously the parent makes the decision, the child just goes along with the ride. But it's the discussion about long-term, lifetime restorative issues of maintenance. First Maryland bridge, then implant, versus less than ideal morphology with canine substitution and again restorative veneering. So either way, you've got lifetime, long-term restorative implications. Don't forget, you finish your orthodontic treatment at 14 and you still got to manage the restorative needs until 100. how many parents insist on closing the space to avoid implants in the future? Well, I think ultimately it comes down to long-term planning of the parents for the child. Implants are an expense, a complication to life in general, large, long-term restorative undertaking. Is it more ideal to have the correct spacing, the correct teeth, and replacement of only the missing teeth? Sure. Will the family anticipate the financial requirements for long-term provisional restorations, followed by long-term definitive restorations, followed by an ongoing lifetime of restorative management? That's just something that the parents will decide on their own. Maintenance of veneers in canine substitution, a much simpler proposition compared to management of a missing tooth and implants to the future. So one is more ideal, but it requires more from the family and eventually the patient. One is less ideal, but requires less maintenance, complexity. Not an easy thing to hold space for a decade or two, and then having to deal also with no bone where you want to put the implants, because you can create space, maintain the space, but how do you maintain the bone? Some clinicians will use TADs as a provisional rather than a Maryland, and those TADs will kind of hold bone a little bit, but you've got to have that in place for 10 to 20 years before you're ready for the implant. And then, of course, you can still augment the ridges with hydroxyapatite grafting, but again, complexity addition. Gingival margins are never as nice in either case of whether it's canine substitution or implants. So, high aesthetic lines, smile lines versus low aesthetic, thin bone, biotype, thin gingival biotype. All these factors need to be discussed with periodontists, with restorative dentists, with orthodontists. So yeah, so that's the head scratching headache for missing teeth. Next question, how often do you revise high frenal attachments in developing jaws? So revision of frenal attachments that pass through heavily into the palate, more often than not, will pose a difficulty in space closure. So frenum attachments that run through from the buccal to the palatal surfaces will not allow teeth to naturally close. And so you'll end up with a kind of big diastema between the two front teeth. Culturally, some cultures that find it acceptable, fortuitous, others the exact opposite. Normally, space closure can be made orthodontically, whether there's a frenal attachment or not, but it tends not to be retentive because the tissues expand the diastema back into place. So the general orthodontic rule of thumb is you revise the frenum after you've closed the space and not before you close the space. Revising the frenum before you close the space can sometimes be problematic because instead of good healing between the incisors, you get fibrous tissue, excessive fibrous tissue here. If that occurs, it's really difficult to close the incisors through the fibrous tissue. So generally, you will close the space first, then revise the freedom after. And then you'll have to still have a fixed retainer for a good many years to stop it from relapsing. Next question. Do you consider training of occipital frontalis muscle in developing craniofacial complex in its growth and maturation? Not something that I'm even aware of, so I don't know anything about that. So the short answer is no.
All right. Are there any other questions? I think that's everything submitted so far. So we got a few more minutes. If you would like to submit one of two final questions, here's your chance. Give you guys just a minute to type it in. Okay, let's see. That's about it. All right. If no one else, just type, I have a question. If you need a minute to type it in, otherwise we'll wrap up. Okay, I think that's about it, Simon. Thank you, thank you. Until next time.
Bye-bye.
All right, thanks. Bye.